Greetings and welcome to week 2 of Psychopathology and Family Systems. I am Dr. Andrea Waddell-Pratt. In class 2, we spent some time looking at historical underpinnings for diagnosing, and that meant that we looked into the early theories, which included supernatural theory, somatogenic theory, and also psychological theory. We learned that diagnosing is not fixed. Instead, it moves with time and should recognize culture and context. Over the years, philosophers and providers went from blaming patients for their illnesses, thus rendering the inhumane treatment, to eventually transitioning to humane treatment and the consideration that stress and experiences might have impact on mental well-being. However, in the quest for the least restrictive treatment environment, much of the care that was offered through long-term treatment facilities like the state hospitals that Dorothea Dix sort of ushered into being, that long-term care treatment has been lost. Instead, many of the individuals with mental illness are being treated in emergency rooms and being shuttled into community mental health centers and group homes when long-term care with skilled and trained individuals is really what is needed. So, in all, you were encouraged to recognize that diagnosing is a significant and fundamental part of the work that we do. And understanding the multi-layered and multifaceted aspects of illness situates and even drives the treatment. In this module and series of slides, we're going to learn about the significance and privilege of diagnosing. As we discussed before, each generation tends to identify what is not usual or what is peculiar for that time. Whatever are those perspectives, they are considered and researched by the profession and included in the DSM. Diagnosing inherently creates an imbalance. It suggests often to the client that there is one who knows, the one that is the expert, and then there is just the client. We want to be mindful of this so that we work to create an atmosphere where the client feels as if they know themselves and that we understand the clinical language from their words. So, diagnosing is a recognition that clients do not speak in psychological language or even in diagnostic terms. Instead, the client tells to us their story, and we find the criterion within those words. Diagnostic language may fail to convey the descriptive experiences of the client. So we get to hear what is happening and then find that in the DSM. Finally, diagnosing means that a shared manual is being referenced by the professionals and that when a diagnosis is identified, there is a shared understanding that the qualifying and necessary symptoms for whatever label has been given have been met. Diagnosing should bring certainty that colloquial language is not being applied. For instance, a lot of people say, oh, this person is up and down all day long. They're bipolar. The DSM does not describe bipolar disorder in that way. So again, when we are diagnosing, we should be ensuring that criteria is met, and that we aren't overusing psychological language in a colloquial way. So, how should the process of diagnosing be framed in your mind as well as with the client? It should be framed as this collaborative process, one that encourages the client's voice and recognizes that the client is expert on their own experiences. The provider is the expert on how the constellation of those symptoms hang together to create a diagnostic picture. The provider is expert in the best approaches for managing those systems and then for transferring that to the client in a language that they can hear and that the client can understand. Okay, so we're trying to create a collaboration here, not only in the mind of the client, but also for you, the therapist. So let's delve a little bit more into collaboration. Collaboration looks like following the lead of the client and creating the necessary space as well as the comfortable atmosphere for them, the client, the family, to share their stories and experiences. So, when it is possible, we try to listen without interruption. We try to see where the client's going to take us and what depth they will articulate whatever is going on. And so we, in that collaboration and the space, just tune our ears to hear meaning within the words that are spoken, as well as those that aren't stated, those that go unstated. So this requires an observation of the entire person, from their tone of voice to their body language. As I've stated before, clients don't speak in DSM bullet points. They tell stories, they share experiences that they've had, and we need to draw from those experiences and stories the symptoms. We listen to the narrative that is being offered, and we try to place the person in the DSM if there is a clinical issue present. So as providers, to get at what we need, we pose a lot of questions using words and language that could actually be viewed as hurtful, right? So when we, and you learn this in clinical foundations, when we paraphrase, right? Here's what I heard you to say. When we provide the diagnostic labeling for what we think we have heard the client share, it can be hurtful. It can sound hurtful. And we want to think about, does what I'm saying, how I'm phrasing, does it suggest a shortcoming or a failure in the person in front of me? Or does it offer hope to the client that change is possible? Or do my words fix some or connote or send the message that their state of being is somehow fixed, right? If those things are occurring, then the collaboration that we're really after starts to become stunted. So, be mindful of language. Be sensitive to how psychological speak can come across potentially in hurtful ways. I always remind students as well, or inform maybe before reminding, that a diagnosis becomes a part of the permanent record of the client. So when you render a diagnosis, you want to do this with certainty. And You want to diagnose with the recognition of the potential future impacts. This doesn't mean that, or this doesn't suggest that you don't diagnose accurately what you are seeing. Instead, it is intended to encourage that you're mindful of the privilege of diagnosing, because the client could also gain access to their record and therefore the diagnosis. So we are in a privileged place when we are diagnosing. So we work and we move with accuracy. So let's talk about creating the atmosphere that allows clients to communicate fully and deeply with us, giving us their story, knowing that there isn't judgment. I'm going to start by really just talking a little bit about the addition of the therapist in a space. The addition of the therapist can either add to, in other words, stabilize, or it can destabilize. The person in front of us can be stabilized by our presence or destabilized. And so as therapists, we desire for our presence to be stabilizing, right? To add to. And as disciples of Christ, we hope to bring light and hope to situations. According to the American Psychological Association Monitor magazine, the therapeutic alliance is not only key in treatment, it also has impact on treatment outcomes. So the introduction of our presence has influence, and we want to acknowledge that in our own minds, as well as recognize the influence and the impact that it could have on the client to engage with us fully. Effective therapists, according to this APA Monitor magazine, effective therapists have mature, strong interpersonal skills, right? They note the characteristics of fluency and warmth and empathy and acceptance. These are important. The person in front of you may be handing you the very worst of who they are or of their experiences. They need to feel a warmth from us and to feel like we can identify how the patient is feeling. Successful therapists are also able to form alliances that are helpful with varied client groups. You're not just good with this group of individuals. A successful therapist can be alliance-based with varied client groups, with different ethnic backgrounds or genders or age or even religious practices. This is possible, right? Because there is no judgment in therapy. There is reflection, there is education, there is encouragement, and there is direction toward the goals that are collaboratively set, but there isn't judgment. Effective treatment and treatment progress, when we try to figure out, how do I know if I've been successful? How do I know if this is effective? We can do that either informally or through the use of outcomes, right? So when I'm communicating with a client and we are at a place where they are going left, for example, when I thought they might be going right, I will speak to the direction that the client is going, but I'm aware that the client may feel my question or my challenge as judgment. But that is exactly the time where I remind the client that I am not judging. I'm not sitting in judgment of their behaviors, but I'm wedded to the goals that we collaboratively set. And so when they are going this way and they are not going in an opposite direction, in the direction toward the goals, I am calling that into question. So notice how in the collaboration, there is an acknowledgement that happens when I give thought to the client perhaps seeing my engagement as judgment. I also do that when the client says, hey, that feels some kind of way. I also remind that, hey, wait a second, I thought this is where we were going, but this action seems to take you in another or an opposite direction. So hopefully you hear in that example how the collaboration and the introduction of the therapist can have positive and stabilizing influence. It is imperative that we understand the task before us. This class is about diagnosing, but the diagnosing then sets us up for the rest of the things to come in the therapy. So we have to understand the task that we have. And our task is to help remove the obstacles in the person's mind, obstacles in their thinking, but it's not punitive, nor is it pejorative speculation regarding the why behind their behavior. We want to refrain from passing judgment. So when we're looking at the why behind behavior, again, it's not intended to be punitive, but it is presented in a way that is curious, okay? We also want to release assumption that all of the anguish that the person is feeling is due to sin or something that the client did wrong. Encouragement, right, from a supernatural theory era. That doesn't mean that clients and individuals, people in general, don't have to deal with the consequences of their actions. Certainly we do, but we don't go into the task believing, what did you do wrong? Because then that means the fix is only in the person when the fix may be external to the client. We also, in understanding the task, recognize that distress could be purposeful for maturation, for somebody to mature, right? So we are not here to remove all troubling, but we are to reflect God. We are to be patient, and we are to gently reveal the knowledge that we have about the person as they can hear it, right? If we say things too early in our reflection about what we're seeing or what we're noticing, it could turn off the client. It could feel judgy and pejorative and make it seem as if the client isn't joining with us in being the expert. So we patiently, gently reveal as the information can be heard. Like I just sort of alluded to, the removal of pain, it's not what we're trying to do. Avoiding pain, I don't believe is God's intent for our lives. Troubling is a part of living. So we release the assumption again about sin, and we recognize purpose, right? And that purpose is intended to mature. And so we are not fixing or changing people. That is God's job to do, to fix, right? Our work facilitates, hopefully, some spiritual, emotional, and personal growth to produce a mentally well individual. Now, let's get an understanding of the clinical interview, because this is foundational to what we do, because it allows us to get the information and the understanding that gives way to the diagnosis, that opens up the diagnosis. Here I have I've listed what are some of the basic components of any clinical interview. Many of you will be at various practicum sites in the months to come. Each site might have a specific form that they want you to complete in terms of gathering information from the client. In the end, though, you should have knowledge of these key areas that allow you to offer a solid case presentation. Traditional questioning may or may not be effective for non-Western or foreign-born individuals. So there are some supplemental forms for information gathering that you might use instead. And the World Health Organization has designed questionnaires that are intended to be universal for this very purpose. One of those is the General Health Questionnaire. And it, though translated into a number of languages, the items may not always function the same across cultures. For example, depression may not be described the same across cultures. It still attempts to create a universal understanding of things, but your knowledge about specific cultures that you'll come to learn will help you to adjust language as necessary. But let's look at these basic components. You have the presenting problem. That is the thing that brought the client into therapy to begin with. And when you are getting information about the presenting problem, you're wanting to know, what is the frequency? How long has this been occurring or been in place? What is the degree of distress or intensity? And what does this particular distress cause in other places? You ought to also want to get some bit of developmental history. You want to understand milestones. You want to understand that the person met language milestones appropriately, that they spoke appropriately, that there weren't any unusual issues at birth. That's what is meant by developmental. If you have a child client, you're going to have a more in-depth clinical interview around this area, but suffice it to say, you want to get some basic early developmental information. When we think about relationship and family history, here's where you're wanting to know about friends, intimate others, marriages, as well as family. And within those interpersonal relationships and peer groups, you want to identify if there is any abuse or trauma present. Has there been marriage? Has there been divorce? Those sort of things. The literature is telling us that more people have experienced traumatic experiences than maybe we ever thought was the case. So this is the time where you ask about the nature of the relationships and whether or not there was abuse or violence or trauma present. Substance use or even other addictions. You want to know how or if these things are present so that you understand how they may impact the presenting issue if it's not the presenting issue, right? It may be the presenting issue, but when you're in this section, you're wanting to figure out when did they start using? How often do they use? How much do they use? Have they ever had periods of time where they attempted to stop but did not? The next thing that you're going to want to know about is treatment. Have they had any treatment? You might delve into that when you're getting into the substance use history. If they've ever tried to stop, was that on their own? Was that with treatment? But many people have had therapy. So, have you had any previous therapy? If so, tell me about it. What did you like about the therapy? What did you dislike about the experience? What worked for you? What didn't work for you? What did you like? What didn't you like? So that the client hears you to suggest in that questioning that therapy is not the way that therapy is conducted isn't going to work for everyone. Every therapist doesn't work for every person. And so what we are doing as therapists seems like it's working, but it may not have. So we elicit that information from the client so that if there is a way that therapy has been conducted that does not work for that individual, then we are looking to alter the therapy so that the client realizes they have been heard. Yes, you heard me. I don't like when blah, blah, blah. Okay? Medical history and problems. We are always getting a thorough assessment of our client. We are not medical providers, but we do want to know if there are medical issues because depending, some medical issues could mimic mental health issues or medical issues could exacerbate the presence of the mental health issues or be the source of the mental health issue, like somebody who has chronic pain, for example, might present with depression. However, as we hear more of their story and ask about medical problems, and they talk about long-standing pain, well, now we understand the cause, right? When we go back to the cause giving way to the treatment, well, now we understand that part of how this issue may have to be attended to is to attend to the pain that leads to the depression. Okay? Legal history is also important, not because we want to judge, but because we want to have some understanding of how the person conforms to societal norms, expectations. If there has been some sort of legal issue, it might lend us to understand if there has been violence in the history or if there's been a legal issue for which they have been the victim but were in essence blamed. We want to know, moving down to religious beliefs and affiliation, we want to know if there are any uh, religious or spiritual components to that person's life, and if they incorporate spirituality and religion and or faith into their understanding of what's going on, if they use that to make sense of what's going on. That lets us know whether or not, when we ask, if they want that to be a part of the treatment or if they don't. I say that because I have a number of clients that may come to me who are Christians, but they aren't interested in religious views being incorporated into the treatment per se, because they don't want to feel that they are being judged for the choices they've made and so forth. We get to honor that, right? We get to honor how the client wants their treatment to be framed. We want to know about the person's education and their work history. It lets us know what they do, how long they've been doing it, the educational level that they may have or had access to, and the privilege of that, what that affords them in terms of lifestyle and experiences. Some of that we can gain from understanding and knowing their educational background as well as their work history. It also gives us a little bit of information about their understanding and how deep or shallow their understanding might be. Somebody who perhaps didn't graduate high school for whatever reason may have difficulties or had difficulties in learning, and so we'll want to know that. They may have some difficulty in understanding language, so we want to be mindful of language. We don't want to assume, but it gives us some information that then, whatever our assumptions are from that, we determine whether or not there is any validity in those assumptions based on what we see from the person in front of us. There's always observation that we're doing, and there's always recognition that culture may determine the effectiveness again of these particular categories. Other categories might need to be included, or even, like I said, other assessment tools. The other thing that we gain from the intake interview is the mental status exam, and we're going to talk about that. When we are interviewing families, there might be additional areas of information that we need to explore before delving into the problem. So remember that the problem first has to be fully understood before we try to create fixes and changes. So we might want to look at critical life events, again, delving into marriage and divorce and the impact of those. Family members who might have suffered with abuse or drugs or had trauma. What is the impact of those critical life events on the family unit or even the person in front of you if it's an individual or a couple? What are the behavioral sequences? How does the family communicate? What are the communication boundaries and rules? Are there hierarchies? And who gets to speak? Who doesn't get to speak? Who receives deference? Who doesn't? All of those things we are observing for. Like I mentioned, questionnaires are key in getting additional information. And like we mentioned before, if we are relying solely on clinical judgment, or maybe I'll say this later, if we are relying on clinical judgment alone, we may misdiagnose. So we want to use questionnaires to help us. This general health questionnaire is the one that was mentioned by that I mentioned was created by the World Health Organization. But clients may be more forthcoming on a paper, pencil, or computer measure than they are in sharing those same details, particularly at the beginning of treatment when rapport is still being established. So, this particular questionnaire is appropriate for master's level clinicians. You might use others to help you get a full grasp of the client and the issues, and we'll be learning about those in your assessment class. But I present this to you at this time because I want to encourage you to be thinking that there is my clinical judgment and observation of the client, but there's also the addition of assessment measures to help me get at the diagnosis. Let's spend a few moments here talking about supplemental considerations when you are interviewing clients. The Holy Spirit should be invited into the therapist's hearts or the therapist's heart and thoughts for discernment. but not necessarily introduced to the client. Again, unless this is what the client is after. The introduction of religion and religiosity and those sort of things, again, can suggest judgment to the client even when that's not intended. So absolutely, invite the spirit into your heart and your thoughts so that you can discern appropriately and accurately what is happening with the client. During the process, you should also be observing yourself. What are you noticing about how you're feeling? How are you taking in what it is you're hearing? What aspects of the story do you seem to be attending to most closely? And is there a reason for that? Are there parts of the story that challenge you? Pay attention to that, right? Because your experiences are also in the room with the client and their experiences. And we want to be observant that we stay focused on the client and that we don't start to allow our stuff to seep into what the client is telling us, such that the assessment that we walk away with is not just the client's experience, but a combination of ours and theirs. Observation is part of the assessment. So you're noticing the interactions, the client with you, the family members with each other, a couple with one another, each person with you, right? Like I mentioned, are there rules of engagement? Who holds the power? Is there a hierarchy? Observe what is being stated, what is going unsaid. What do you notice about glances? Try to identify and understand the invisible structures that maintain this referral issue. Here I have offered you an example of a mental status exam. And a mental status exam is really looking at behavioral and cognitive functioning. And so as well as appearance and general behavior. So you are assessing the level of consciousness and alertness of the person, their motor behaviors and speech. You're making an assessment of their mood and affect. Mood being how they feel, affect being the representation or expression of that mood, how they look. They say they're depressed. Are they looking and acting depressed? You're looking at their thoughts and their perceptions. You're assessing attitude and insight. Insight is important because it helps you to understand how well they understand what is going on with them. You're also looking at their cognitive abilities, the language they use, memory, how they construct language, as well as their abstract abilities. You are attempting to assess memory, long and short term. You're also looking at their language abilities. Now, here I've listed reading, writing, speaking, and comprehension. You're not doing anything formal here, but you are paying attention to how well they can follow the language, how well it seemed that they read the forms. If there's any writing that took place, you're reading how they conveyed their thoughts through writing, and you're taking a guess at their ability to comprehend and understand. So make sure you take a good look at this, because this sort of rounds out the clinical interview and again helps to give us the foundations needed for understanding what it is we're hearing so that we can be accurate in our assessments.